Hi, I'm Noah Ivers, the family physician at Women's College Hospital in Toronto. On behalf of Dr. Karen Tu and the whole EMRALD-IFIS team, I'd like to thank you very much for joining this presentation. I'll be describing the tools our team has built to help support your quality improvement efforts, and we'll be focusing on atrial fibrillation, as we have received funding from Heart and Stroke to conduct this project. The first thing we'll do today is to briefly summarize the latest atrial fibrillation guidelines. A brand new version of the Canadian Cardiovascular Society guideline for atrial fibrillation was released in October 2014. We'll discuss some of the highlights and show you some resources that you can use to quickly access the recommendations whenever you need them. Then, we'll talk about how you can use the EMRALD-SAFIRE website to get data about the proportion of patients in your clinic that are achieving best practice quality indicators, and to identify patients who may benefit from reassessment. Next, we'll show you some tools we've built for your EMR that make it easier to manage patients who have atrial fibrillation. Finally, we'll be sure to leave plenty of time for questions and discussion. Before we go any further, I want to spend a moment describing why we wanted to focus on atrial fibrillation. It comes to this. Atrial fibrillation is an important risk factor for serious stroke. Anticoagulation reduces risk of stroke by close to 3/4. Yet, studies from Ontario and around the world consistently find that we are undertreating our patients with atrial fibrillation, even those with multiple comorbid risk factors. What's more, even if we start an anticoagulant, research suggests that patients often discontinue it or have quite suboptimal adherence patterns. Almost 3/4 of strokes caused by atrial fibrillation are either fatal or cause permanent disability. So this is really important stuff, and data suggests there is a great deal of room for improvement. To go along with the latest guidelines, we published in the Canadian Journal of Cardiology a primer on applying the guidelines in practice. We described 4 steps. First, assess for causes that might make symptoms worse, including sleep apnea. Second, assess the impact of symptoms on quality of life over time, and make treatment decisions regarding rate control or sometimes even rhythm control accordingly. Third, conduct a formal assessment of stroke and bleeding risk and follow the CCS algorithm to determine appropriate treatment. We'll go through that algorithm in a moment. Finally, the 4th step is to plan regular follow-up to monitor both symptoms and adherence. To assess quality of life, you can use a scale similar to those that are commonly used for angina or heart failure. The point of giving somebody a score is that you can quickly determine the trend over time and use this to adjust your rate control prescription or possibly refer for rhythm control if you choose. This is a flow diagram from the guidelines that provides guidance regarding rate control options. Basically, it highlights that beta blockers should be used if the patient has coronary artery disease or congestive heart failure. Fortunately, most family physicians are fairly comfortable with using beta blockers. The aspect I want to focus on is our role as primary care providers in reducing risk of stroke. As mentioned previously, AFib-related strokes are often quite severe. This must be contrasted with the risk of treatment, but it's important to remember that GI bleeds are much less likely to cause mortality or permanent disability than a stroke. So it's inappropriate to give equal weight to the risk of stroke and the risk of bleeding. And so here is the promised CCS algorithm from the latest guidelines. What it says is that any patient who is 65 years and above should be offered anticoagulation therapy. Those younger than 65 should be offered anticoagulation if they have any additional stroke risk factors, such as a previous TIA, or hypertension, or heart failure, or diabetes. If they are younger than 65 and do not have any of those risk factors, but they do have vascular disease, they should be offered aspirin. In general, the guidelines recommend the novel oral anticoagulants in preference to warfarin, but the difference between anticoagulants is much, much smaller than the difference between anticoagulation and aspirin, and certainly much, much, much smaller than the difference between anticoagulation and no treatment. The important thing is that higher risk patients are started on an anticoagulant and that long-term adherence is supported. This brings brings us to highlight the importance of proactive follow-up. I've already mentioned how changes in symptom over time could be used to inform treatment decisions. Of course, blood pressure should also be measured regularly in these patients, given our concern about stroke. Then, although the newer agents do not require regular INR testing, they do require periodic measurement of renal function, and patients need frequent reminders regarding adherence because the half-life of the new drugs is very short. We've helped to develop a summary of all these recommendations in a one-page document. Feedback so far about this one-pager has been really, really positive. You can find it anytime by Googling Afib in one page, or by using the link on this slide. Now I'd like to switch gears and talk about how you can access data regarding your own quality of care. This slide shows how to log into the EMRALD-SAFIRE website. Each physician or their delegate can sign in at any time to access the data. Once you log in, you will see data regarding the proportion of patients in your practice that are meeting best practice quality indicators. The metrics focus on stroke prevention therapy, as well as management of blood pressure and heart rate. Along the top, you'll find a frequently asked questions tab that explains how each of the metrics are calculated, and it also includes brief videos showing how to use all the different functions of the website. In the bottom right corner of the screen is a graph that we call the gap score. This depicts the number of patients who have one or more metrics that could be improved. You could use this information to focus on patients who have the highest gap score. Another way to look at the data is to try to use what we call high-risk metrics. This approach shows the proportion of patients in your practice that are above what might be considered a high-risk threshold, such as patients with atrial fibrillation who have not had a blood pressure measurement in well over a year. Again, the gap score can be used in the same way to prioritize patients who may benefit most from a reassessment in clinic. To identify the patients, you simply click on the blue button near the top of the page called Patient List. This is an illustration of what your patient list might look like. You can click Download to extract the data to Excel, where it is easy to sort by any number of variables. Then you can proactively prioritize follow-up appointments accordingly. If there are some patients in the list that should not be there, you can click the button to exclude from future analyses. We've gotten approval from the CFPC to provide you with 2 main Pro C credits for each disease condition you review on the EMRALD-SAFIRE website. To get the credits, you just review and complete the form you see here. It's preferable to review the form with your team to come up with systems and plans that can benefit all your patients. When you submit, you get a certificate that looks like this. Now I want to switch gears again to look at the tools we have built for use within your EMR. What you are looking at on this slide is a picture of what we call the Afib toolbar. This acts as a rapid access point to the tools that we've developed for you. You'll see soon how it works. One of the tools that I want to focus on is the stroke and bleeding risk calculator. Every atrial fibrillation guideline around the world recommends formal assessment of stroke risk, and in the UK, doing this is part of their paid-for-performance scheme. Our tool is installed as a custom form, and when you activate it in the patient's chart and click the buttons for the relevant risk factors, it automatically spits out a recommendation that we've carefully programmed to be concordant with the guidelines. You'll see in just a minute exactly how this works. I also wanted to introduce other interactive custom forms we've created. This one that you're looking at now guides the health professional through a structured assessment for patients who have atrial fibrillation, following the usual SOAP format. It helps to quickly assess relevant symptoms, record the relevant physical findings, organize the relevant lab work, consider current treatment regimen for both stroke prevention and rate control, and then make a plan regarding whether to stay the course or make some changes. We'll show this live in just a moment. Before we do that, I want to introduce one other thing, and that is the requirement to set up reminders in the system to make the toolbar work. We try to make this as easy as possible and are happy to guide somebody from your clinic through the process. It takes less than 10 minutes. While we're at it, we can help you to build and run some simple reminders to identify patients that may be overdue for testing, like patients taking warfarin without a recent INR, or patients taking a new oral anticoagulant without a recent kidney function test. Now I want to spend the next 5 minutes showing a video that shows how to use these tools. Please watch it with us. After this, we'll spend plenty of time dealing with your questions and having some discussion.
Hi, I'm Dan Legg, a research assistant working at ISIS on the EMRALD project and supporting SAFIRE, the System for Audit and Feedback to Improve Care. Together with a number of primary care provider colleagues, as well as support from Cognizant MD and the Center for Innovation in Complex Care, we've developed tools that we hope will help you care for your patients with atrial fibrillation. As you can see, this patient is a 92-year-old man with atrial fibrillation. Because atrial fibrillation is in his problem list, the Afib toolbar becomes visible. This brief video will summarize the features of this toolbar and of the tools it contains. We have set up this toolbar to include quick access to features that might be helpful for you when caring for a patient with atrial fibrillation in primary care. From left to right, there is the quick access to a custom form for completing an initial assessment for patients with a new diagnosis, a custom form for completing a follow-up assessment during routine ongoing management, a custom form for calculating stroke and bleeding risk to inform stroke prevention treatment decisions, a link to patient handouts, a link to provider resources for managing atrial fibrillation, a flow sheet for relevant labs and vitals, and a link to graph the INR if relevant. The provider resources contains a summary of the guidelines known as Afib in one page. We have a separate video that explains the content of that page. We've also created videos showing the initial form and the risk calculator in detail. If for some reason the toolbar does not appear, the custom forms for the initial assessment, the follow-up visit, and the stroke and bleeding risk tool can also be opened through the usual approach to accessing custom forms in PS. For a routine visit, you may start a note as usual to determine the patient's chief complaint, but when you recognize the patient has atrial fibrillation, you may wish to structure your clinical assessment for that condition. If so, you may consider using the follow-up visit custom form. Clicking on the follow-up visit button on the toolbar opens up a structured approach to building a SOAP note for Afib. Although it may look like a lengthy note, when you click Finish, it gets reorganized into structured summary, as you will see in a moment. You can quickly assess systems and side effects by clicking once for no and twice for yes. Identify the impact on quality of life. And make any additional notes that might be relevant. Then you can enter the physical exam here. The relevant labs will be pulled into your note here, or you can identify the labs that are followed by a specialist. The Assessment and Plan section focuses on decisions regarding stroke prevention and symptom management. In both cases, you identify a current treatment, the patient's adherence, and can make notes about whether this approach seems to be working. For your plan, you determine whether to continue or change the treatment. You may also wish to identify the labs that should be done and suggest an interval for follow-up. If you want more info to make these decisions, quick links are available within your note. Here you can get prescription details for rate control agents, and here you get details for the oral anticoagulants. Then you can click Finish and the note is created. At any time, if you're unsure whether an anticoagulant is recommended, or you want to take the patient through the stroke prevention treatment decision, you can use the stroke and bleeding risk calculator from within the follow-up form, or by clicking on the tool in the toolbar, or finding it in the custom form in your EMR. To use the calculator, click on the appropriate characteristics for your patient. After choosing the relevant factors, use 92, you can calculate the risk. You will see that a recommendation appears which we carefully programmed to be concordant with the CCS guidelines. If you missed a relevant risk factor, you can still click on it and the recommendations will change accordingly. So for abnormal liver function, we hope you will use the risk calculator together with your patients so that they can fully understand the risks and benefits of stroke prevention treatments. When completed, the assessment gets added to the progress notes. This is a simple and quick way to periodically assess and document your patient's risk of stroke and related management recommendations. My colleagues and I believe that these tools can help to ensure that patient management of this condition is both evidence-based and patient-centered. We encourage you to use these tools to provide us with feedback about them.
Thank you so much for joining us. I hope you found that presentation helpful. We're pleased to hear feedback from you, so don't hesitate to send comments or questions. Please remember, guidelines don't self-implement, tools don't self-install, and change doesn't just happen. Help us work with you so that we can all benefit our patients.